Okay, let's talk about treatment of NTM. And what I'm showing you here is kind of the history of the guidelines. So the first NTM guideline, turn up. Boy, it sounds loud up front. How's that? Okay, so the first NTM guideline was published in 1990. It was revised 7 years later, then again 10 years later, and now we have the 2020. That's what we're all working on clinically. That's the one that we use today. So that was published 13 years after the last. We couldn't cover everything. There's 200 species. You can't write a document covering the treatment of 200 species. So we had to focus, and we focused on the most common species of NTM to cause lung disease. But we did come back later and say, well, there are others that cause disease. So we published another document in 2022. And this one was to cover the more unusual NTM, not MAC, not abscessus, which we'll be talking about today. So there are guidelines out there for your clinicians if you were to grow one of the more unusual organisms. So remember, 200 species. So what we did in the guidelines was focus on the three most common, what we call slow growers, because they take over a week to grow. That's MAC, which is Mycobacterium avium complex. It is Kansasii and Xenopi. For the rapid growers, we covered abscessus. And in this other document, there's a list. Many of these you probably have never seen nor heard of, but your physicians may, because they may get a report someday that you're growing one of these organisms, and these are the recommendations of how to manage that. So if you were to grow tuberculosis from a respiratory specimen, you have TB. That's it. And we put you on TB treatment. But if you grow MAC or abscessus or one of these other 200 species, we have to think about it, because it doesn't always mean it's harming you. Remember, they're everywhere. So if you just were sitting in an indoor hot tub, which I hope you weren't, but if you were, maybe you have some in your respiratory tract and we just happened to grow it that day. But maybe the next week or 2 weeks later, it's not there anymore. So we have these guidelines that are called, they're diagnostic criteria that are in the guideline. And these are a guide for your physicians to try to help them think through, should I treat this person or not? So it starts with the fact that you come in with symptoms, cough, fatigue, weight loss, things that we think about, or we should be thinking about NTM. We're going to get a radiograph. Hopefully they're going to get a CT at some point, because that's how we diagnose bronchiectasis. It can be difficult from a chest x-ray, but we can see NTM on a chest x-ray sometimes. In this bottom panel, in the right part of the lung, it's been destroyed. Looks like tuberculosis, but in this case, that was a patient with MAC, and they had cavitary MAC. The top panel is the typical, what I was talking about earlier in the nodular bronchiectatic category of MAC. Either one of these can be disease, but just seeing that top panel does not tell me that if you grow MAC, that's just bronchiectasis. That's not just MAC. MAC are the little nodules that we see, or the bigger nodules, or the cavitation. So when we read a CT, we have to look at it in terms of, is there bronchiectasis, yes or no, and how much is there? But also, do we see findings suggesting NTM? And they're different. But ultimately, I have to grow this from your sputum to say you have any NTM. I got to know which of the 200 species is there. Is it one that I would treat? Is it one that I may not treat? The guidelines want to see 2 positive sputum cultures. So we can't say you have MAC disease unless you have grown it at least 2 times. We would like to see in most patients multiple positive cultures over weeks to months before we're convinced that this is probably harming you. So if you have a physician and you grow it 1 time and they go, let's start treatment, we would say give pause to that. Let's slow this down. If there's any good thing about NTM, they grow slowly and they progress slowly. So it means we have time to make the right decision. We shouldn't have to rush into it. So If we're not going to treat everyone, then we might consider what we call watchful waiting, meaning we're going to monitor you for any evidence of progression. And we have data to support doing this. But we also have data to support in certain people, we should not do watchful waiting. We should initiate treatment. So in the guidelines, we asked a question that we looked at the literature to see if we could answer, and that is, do we treat everyone or not? A recommendation was in people who meet the diagnostic criteria that we just looked at, that we would suggest initiation of treatment, particularly if they have a high bacterial load. You know, the more you're growing in your cultures, the more convinced I am that it's harming you. Or if the radiographic findings like cavitation are present. So just to give you an idea, these are two studies that were from Korea. They started off with 500 or so patients who had MAC pulmonary disease, and they met the diagnostic criteria. So that's when I have to decide, should I be treating you or not? They followed them for almost 6 years off of treatment. So what happened to them? Well, in the first study, almost 63% progressed during that time period. In the other study, it was about 60. So they found very similar things, two different sites in South Korea. So my interpretation is for most people who meet the disease criteria will progress. It's just how long and when. But 24%, 41% were stable during that time, and half of those spontaneously converted their cultures to negative without antimicrobial treatment. So we do know there's a subset of people who don't seem to progress and even become negative again, which is why we have to be really convinced that someone has the disease. And that's more positive cultures over time is the most convincing to me. The other thing is radiographic progression. If you and I are sitting in clinic looking at your CT and we see that the nodules are getting worse or cavitation has occurred, it's time to treat. I think we would all agree on that. Now, these studies also helped us figure out risk factors for progression. So that now I'm sitting with you in clinic and these are running through my head, thinking, do you have these risk factors? So host factors, it turns out males are more likely to progress, women are more likely to get the disease or get infected, but males are more likely to progress. People of older age, people who have other comorbidities, and people who have a low body mass index. So nutrition is really important, and that's why we always have a nutritionist present at this conference. But we can do laboratory testing, and some of those are associated with progression, like elevated C-reactive protein, anemia, low albumin, which is a protein in the blood. These are all signs that suggest that progression is more likely. The radiograph, really helpful. If we see cavitation, progression has already occurred. It is time to treat. And if we see very extensive disease, it is also something that's associated with progression. And then finally, I mentioned the bacterial load. The more you're coughing up, the more we see in the microscope, the more positive cultures you have, all signs of a high bacterial load. And the species, of those 200 species, they're not all the same. Some don't harm humans. Some are very harmful to humans. Many are in between. And we have to figure out, is it harming you? So let's think about what we do in the clinic. I have 3 things I really have to consider when I'm thinking about treating. One is you. The other is which species you're growing. And then the third is, what are the goals of therapy? Unfortunately, for some species, cure is not a word we use. Control is the word we use. And for other species, cure is the word we use because we can cure it. So let's break this down. So from the patient perspective, I'm looking at that list. Do you have any risk factors for progression? If you have multiple, I'm much more likely to treat you if you have none. Do you have symptoms? You know, the joke in medicine is if you don't have symptoms, I can give you symptoms by giving you 3, 4 drugs. So I'm much more likely to treat a very symptomatic person than an asymptomatic person. And then, as I've already mentioned, if I see cavitation or very extensive disease, then that's going to push me to treat. This is an example of what happens with watchful waiting. But in some cases, we're not watching. And that's the mistake we make. We tell you we're not going to treat now, and you may hear something different, like, I'm okay. So this 65-year-old woman with a chronic cough was getting treated for bronchitis 2 to 3 times a year. 8 years later, you can see there's been progression. So we would like that not to happen. We would like to catch that much earlier. And so watchful waiting means what it sounds like. We're going to be seeing you, following you, getting sputum cultures, periodic imaging, so we can diagnose the MAC as early as possible before we get more progression. So what about the organism? Because of the degree of pathogenicity, which is the ability of the organism to harm you, change is variable. This is just a representation of what I'm referring to. So let's start it on the left at 0 and go all the way to 100. So this is a pathogenicity scale. So if you're an organism on the 100%, that meant whenever you grow it, it causes disease. And on the other side is when you grow it, it almost never causes diseases. So you can see how this changes across the species. So Mycobacterium sulgi, Chelidum genovese, in this study, most of the people who grew it, they were felt to have disease. If you grew Chelonae, alveoli, things you've never heard of, Simii, almost never caused disease. But look what's in the middle. Mycobacterium abscessus, Mycobacterium avium, Xenopie, Kanzasii. These are ones that we treat all the time, but we don't have to treat everyone just because you grow it. So it is very important to know the species that you're growing so that I can decide whether I think it's pathogenic or not. And then the goals. So what are we trying to achieve? Are we trying to achieve cure? Sometimes we can, sometimes we can't. We have to be honest about that. Are we just trying to get you converted? So because once we do that, we can treat you for 12 more months and we can get you off medicine. You may get it again. But conversion is one of the things we're trying to achieve. You want me to get rid of your symptoms and I want to do the same thing. And so that's one of the goals. Prevention of progression, if I can't cure you, can I at least stop it in its tracks so it doesn't get worse? And then how about all of the above, right? Because that's what we really want. So this relates to this idea of cure. So if someone grows Mycobacterium Kanzasii, and I think that they have disease due to it, and I start them on a regimen, almost 100% of the time, I'm going to cure them. We love Kanzasii. I don't like Kansas because I'm a Bronco fan, but that's a different thing. And then what if they grow MAC? Look at the ability to have a successful outcome is quite variable. 56 to 85% has been published. And it's often based on the extent of disease. So if someone has cavitary disease, it might be closer to the 56. If they have mild nodular disease, it might be closer to 85. If they grow abscessus, it gets even wider, 25 to 80% success. And that is based on which subspecies they grow. Hence, the lab here is very important because the lab has to tell me which subspecies you have. Most laboratories do not do that. So here I am in the clinic, and this is what we're doing together. We are weighing kind of the pros and cons, the risk and the benefits of starting treatment. So if I was going to do watchful waiting, maybe you have a less virulent NTM, maybe you have very few risk factors for progression, maybe you're not very symptomatic. These are the things that may keep me from saying, let's start treatment now. Let's keep an eye. Let's do the airway clearance first. Let's prevent the GERD. On the other hand, if you grow a more virulent species, you're more symptomatic, you have more risk factors for progression, that's going to push me. So this is much more complicated for a clinician to try to make these decisions. If it was TB, it's easy. They give you the same drugs everywhere in the world. You grow it one time, you've got TB. This is harder, and clinicians, this is more difficult for them. Now, why do we try to make an early diagnosis? Why do we want you to get on therapy as soon as we feel like it's harming you? Well, one, I just showed you, most people, about 60% will progress in a period of 3 to 6 years. So do we want to wait for those 3 to 6 years, or do we want to start earlier? Lung function declines. We showed this in a study in Korea, that when you just follow people over time off of treatment, their lung function declines. Not everyone, but on average did. And then the scariest part, 5-year all-cause mortality has been reported to be 10 to 33%, 5 years. It's not usually due to NTM though. It's usually due to their underlying lung disease or comorbidities. Remember, this is occurring generally in an older population. They have other things. And a very important finding in one study was that mortality was higher in the untreated group. So there looks like there may be a benefit to treatment. You can't say at an individual level if that will happen, but on average, it looks like there was a benefit to treatment. Now here's the background. So treatment. Which treatment regimen am I going to recommend? It's going to be multiple drug. We can never treat with one drug. We'll just get resistance to that drug, and then we lose it forever. It's going to vary by the species, but no matter which species, I'm going to be given a very similar cocktails of drugs, and there's going to be side effects. And we'll talk about those and how we're going to monitor for them. Treatment duration is long. You don't like it. We don't like it. We would love to get this shorter, and we need new drugs to do that, and I'll share some of that with you later. But we're treating for 12 months from the time the cultures become negative. So if you're on treatment, your provider should be getting cultures every 1 to 2 months, because if they turn negative at month 3, we add 12 months, and that's 15 months. It's all based on when your cultures become negative. Treatment outcomes, I just showed you, varies by species. All right, so let's first talk about MAC, Mycobacterium avium complex. Note that the word complex means a collection of species, right? So MAC is not a species. It's actually a collection of around 10 species, and here they are. So this is what's called a dendrogram. It shows how genetically similar organisms are. And this little cluster there are species, and some of these are now subspecies that are called MAC. Now, I would bet most of your physicians' laboratory reports don't name these. They call it MAC, and then they stop. But some of these don't seem to be very pathogenic to humans. And if you grew Mycobacterium marcescens, I may not be as anxious to start treatment as if you grew Intracellularity. We know this, reference centers know this, but most community physicians don't get this kind of detail, and it's just MAC. So this is the 35-year-old woman. I present her because we think we're all going to be 60, 70 before we get this. That's not true. We see young people with this also. Very healthy individual. She had a cough of several weeks duration. I'm going to point here. There's a cavity up in here. Better seen here. So we see a couple of cavities here. And this person grew MAC, and we treated them. How did we treat them? Well, these are the drugs we use to treat MAC and other slow growers. So the most important are the macrolides. We heard earlier today, azithromycin is the one we like to use. Clarithromycin is similar, not quite as well tolerated. Then we add a rifamycin, usually rifampin, but sometimes we use rifabutin, and then ethambutol. If you don't tolerate one of those, or maybe something becomes resistant, then I have to move to the right to this alternative list. And then sometimes, although rarely, we might be able to use something like ciprofloxacin or moxifloxacin, a class of drugs called the oxazolidinones, bedaquiline and clofazimine. So that list is not very long. And so we need new drugs. We might need to use an aminoglycoside like amikacin, an old drug like streptomycin, but mostly now we use amikacin. And now we have the availability to give you inhaled amikacin. So everything you see in front of or behind me now, that's it. This is what we have to treat MAC. Now the lab is very important here because the most important drug that I mentioned is the macrolide, azithromycin. I need to know if that is susceptible. If it isn't, I can't use it. And it completely changes what to expect. So this is kind of a common report. The doctor is going to, or provider is going to see that it's M. avium complex. They won't tell them which species. And then they'll give them a susceptibility report, and they just tell them it's resistant, susceptible, indeterminate. They don't tell them how much. And this is useless. What we would like them to do is to say how many colonies, which species, in this case, even which subspecies it is, and then provide what are called minimal inhibitory concentrations. These numbers are helpful to us. The lower they are, the more activity we're seeing. The problem is, for some of these, they don't mean a whole lot. Only the ones I bolded, amikacin and clarithromycin, if it's resistant to those drugs don't work, and we won't use them. But you may see that it's resistant to other drugs, and we really don't know if those work or not. In other words, it says it's resistant, we've given them to patients and they respond well. Or it may have said susceptible, we give them to patients and they did not respond. So the only two that we really trust is the resistance determination for amikacin and clarithromycin. And these are now the two regimens that are recommended in the guidelines. So remember those x-rays I showed earlier this morning. This is how we decide which regimen you get. If you have cavitary disease, you get one. If you have non-cavitary, you get another. So let's start with the nodular bronchiectatic. We recommend 3 drugs: azithromycin, rifampin, and ethambutol. And if you don't have cavitation, we might recommend you take it 3 days a week. If you do have cavitation, things change. Now we want 3 or more drugs, and the 4th drug is usually intravenous amikacin. And we usually give it for about 2 to 3 months. We can give that 3 times a week, but we want you to take the oral medicines every day if you have cavitary disease. And then we're aiming for that 12 months after culture conversion. So this is just breaking that down step by step. So you grow MAC. I'm waiting for the culture results. I need to know, is it macrolide susceptible? So I can tell you which regimen to take. So let's say it's susceptible to the macrolides. Then I have to look at your X-ray or your CT and see if I see cavities or not. If I see cavities, I'm going to give you azithromycin, rifampin, and ethambutol, daily therapy, and I'm going to consider the addition of IV amikacin. If there's no cavities, then I may give you 3 times a week. We have to adjust the doses depending on if it's 3 times a week or daily. If you're unlucky enough that the isolate is macrolide resistant, then it's harder. We've lost the best drug. We're going to continue the rifampin and ethambutol, but now I'm going to go down that list of alternative drugs and probably try to pick another 1 or 2 and also add IV amikacin for macrolide resistance. So it's a stepwise process. And if we do this, this is what we would expect. This is what I'm going to tell you in clinic. If we're going to start treatment, here's what I want you to consider. Macrolide susceptible, if you have no cavities, then we're going to expect the cultures are going to convert in 70 to 80% of people. If there's cavity, I'm going to tell you it could be lower than that. Depends on the size of the cavity, for example, or how many cavities. But recurrence is common. Up to 50% of people who we do get rid of the MAC, they get it again. And 50 to 75% of the time when they come back with a second episode or a third episode, it's a different strain. It's not the one that we just got rid of, because I didn't get rid of your bronchiectasis and you went back to the same environment and you got infected again. So that shouldn't surprise us that there's a high recurrence rate. If it's macrolide resistant, David Griffith, who will be speaking after me, published years ago that if you take someone with macrolide resistant disease and you don't resect the worst part of the lung and you don't give them the amikacin or the streptomycin in their IV for 6 or more months, only 5% culture converted. So it's almost incurable. That's why we can't lose the macrolide. We did a study in Korea that we did some surgery on selected patients and some got prolonged aminoglycosides, and we got it up to 15%. And in the original study by David Griffith, in his patients with macrolide resistant MAC, if they did do lung resection and gave 6 or more months of intravenous aminoglycosides, he could get culture conversion back up to 80%. but it was a significant cost to the patient, had to undergo thoracic surgery, some hearing loss related to the AMICase. So we would much prefer to prevent than treat macrolide resistance. We now have this new category that we came up with in the 2020 guidelines, and that is treatment refractory disease. Because I showed you that 70 to 80% of people will culture convert. Well, that means 20 to 30% will not. And so they're treatment refractory. And we define that as that once we start treatment with what we call guideline-based therapy, that if people are still culture positive after 6 months of treatment, they're treatment refractory. Something's not right. We have to step in and do something. And what we recommended in the guidelines in people who have treatment refractory disease, that we add this new drug, amikacin liposome inhalation suspension, we'll call it ALIS, easier, to their regimen. And this was one of few, there are only 4 strong recommendations in the new guidelines. All the others were kind of weak recommendations because of lack of evidence. Here we had strong evidence. So what this shows is the results of the phase 3 study. It was called the CONVERT study. It was a nice name because we're trying to convert our patients. And people got randomized if they were still culture positive at 6 months to get ALIS added to their therapy or just stay on their therapy. Don't make any change. Because in the past, that's what we did. We just tell you to stay on, we'll see how you are in 12 months. So the darker bars are those who got the ALIS and the guideline base. And what we're seeing is the percentage of people who converted. So at 1 month, you can see 15% of those who received ALIS added to the regimen were converting, about twice what was happening to those who were just doing the same. And if we go out to 4 months, it was almost 30% conversion versus only 9. So we learned an important lesson here. If we don't make a change at that point, nothing's going to change. But if we added ALIS, we can see a 30% improvement in culture conversion. So that's why the strong recommendation. So that added the third type of treatment, and that is in treatment refractory disease, 6 months of after 6 months of treatment, still culture positive, we add ALIS. So in summary, MAC should be treated with a macrolide-based regimen, and that means azithromycin. An aminoglycoside should be used if there's cavitary disease. Usually we start intravenous for a couple of months, and then we may transition to the inhaled. The duration that's best, we don't know. There's never been a study looking for the optimal duration. We continue to use 12 months beyond culture conversion. We plan to cure most people with MAC, but there's that treatment refractory group that we cannot unless we add ALIS. And as I said, recurrences are common, usually due to another strain. So let's switch to abscesses. This is a patient of mine, 68-year-old woman, chronic cough and fatigue. She presented with these cavitary lesions, cavity here. We can see them, always see them better on a CT scan, multiple cavities, bilateral, extensive disease, grew MAC, grew abscessus. I treated both. How many drugs would that take? Yeah, a lot. 7 probably to start. We got rid of the MAC. Never got rid of the abscessus. It was too extensive by the time that we saw her. So, but it can cause cavitation just like MAC can. So this is just going to briefly give you the history of the name because it keeps changing. And it's confusing to clinicians, it's confusing to our patients. In 1953, in that knee, that's an x-ray of a knee, Mycobacterium abscessus was isolated, but it was a new species. It wasn't named until 1992. Many years later, it was finally named. The name was changed in 2006. Scientists said M. abscessus is actually 3 species. Abscessus, Massiliense, and Belledii. So that's what the lab started to report. 2011, someone said someone created a no-no. You didn't follow the convention for naming, and they took the name away of Massiliense. And then they combined them into 2 subspecies. That was a mistake because Belledii is very rare. most everything that was called Bellettii for a number of years was actually Massiliense. 2013, I was involved in a study in Korea, and we said, no, these are 3 subspecies, reinstate the name Massiliense. That was confirmed by another group, and that is now the official way we look at it. Mycobacterium abscessus has 3 subspecies, and you'll see in a moment that's very important to understand that. So here are the drugs. If I'm going to treat you, these are the drugs that we're going to use. We start, hey, look, the macrolides are there. Also very important for abscesses. Those oxazolidinones, the cyclines, clofazimine, bedaquiline, many drugs that you probably never heard of, but they're used for other things. We might need to move to an alternative. Here's where we're in trouble. We have very few oral medicines for abscesses. It is a highly resistant organism. And that's where we struggle, is building a good oral regimen. We have parenteral drugs that work. So most of the patients are started on a parenteral regimen for a period of months. And we can also consider the use of inhaled amikacin. It would be off-label because it's not approved for the treatment of abscesses. It's approved for the treatment of treatment refractory MAC. But we know that it has activity against this organism. So the most important thing for us to understand when we treat you, when you have abscesses, and what we need to learn from our laboratory is whether it's resistant to the macrolides. It's the same concept as with MAC. So there are 2 ways that this organism can be resistant. Mutational resistance is just, there's a mutation in the gene and the drug does not work. We're not going to use that drug. It doesn't work. But much more common is this other type of resistance that we don't see with MAC, but we see with abscesses. It's called inducible. So what happens is we put it in the laboratory, we put the macrolide in mixed with your isolate, and we see, does it grow or not? Or does it kill it? On the first few days, it looks like it's not killing it. And so the lab says it's susceptible, this works. But 14 days later, if you check again, it's not working because we turned a gene on called an ERM gene. And after over a period of a couple of weeks, what was susceptible is no longer susceptible. So the laboratory has to report this. So this is just kind of a visual idea. So we have Mycobacterium abscessus, subspecies abscessus, kind of the true abscessus. It has this gene, it's called an ERM gene. About 80% of the time, it has this gene. There is about a 20% where there's a mutation there in the ERM gene. And so if you have an ERM gene, that means that it will induce that resistance and that macrolide will not work. So your clinician should not use it unless they're using it for other reasons. If it has that mutation, oh, it works. And we're very happy to see that. That's about 20% of the time. The other subspecies, Massiliense, it has the gene, but it's short. So it doesn't work. That's great. That means that you will not have inducible resistance and you can use the macrolide. And that's important. And the other one, which is rare, it has the gene, and so we can't use the macrolide. So the report may come back to a clinician saying, this is M. chelonae abscessus group. What does that mean? Chelonae is a different species than abscessus. We treat them similarly, but differently, and one does better than the other. So why would a lab report it this way? But this is often the way labs in the US report this to the docs. They don't get the information. And again, they get inadequate susceptibility test results. What they should get is some idea of how many bacteria are there. We should know that it's abscessus, not whether it might be abscessus, and which subspecies. And then if you're really lucky, like we are, we get some molecular data that tell us if that gene is there, if the gene is too short, or if that the good mutation is there. So I know now, should I use the macrolide or not? I have all the information I need. And then we'll have what's called phenotypic. And just like with MAC, the only 2 drugs that we really trust the results of are the macrolides and amikacin, because if they are resistant, the drug does not work. The patient does not respond. You can see the difference in what the lab makes in terms of what they provide to your clinician. Very important. So let's go through, same idea. Looks like the MAC thing. The first step is to know, is it macrolide resistant or not? Let's say it's not. That would be Massilience or the good abscessus. So we'd start the macrolide. We would be picking from this group of drugs, mostly intravenous drugs, usually treat for about 2 months with the IV, and then we go to oral. If it is resistant, then it's probably abscessus or Belledii. It's the same approach, but now I can't use the macrolide. And that's, as you'll see, is really important. So when we don't have a macrolide, we lose some efficacy. These are 4 small studies that looked at patients with and without cystic fibrosis, in which they sequenced and could tell you if it was the good abscessus or the bad abscessus or the good abscessus, which is Massilience. And look at the difference in sputum conversion. If someone had abscesses, only 25% conversion. If they had Massilience, almost 90%. Huge difference based on whether the macrolide was available to treat. So this is critical for us to know as a provider, and we have to get this information from our laboratory. Now, I'm going to end with this idea that if I can't cure my patient with antimicrobials, maybe surgery would be of some benefit. This is a patient with abscesses who had a video-assisted thoracoscopic procedure. You'll hear about that later today. And we were able to get rid of their abscesses. Not just with the surgery, but also with antimicrobial therapy. But I was not able to get rid of it with just antimicrobial therapy. And there are a couple of studies, one from Korea, that showed people with abscesses who had surgery, a medical care, 58% culture conversion. But if they had surgery, it jumped 30%. And a study from here, Julie Jaron, 39% without surgery, jumped to 65% with. So if you come here and you have abscesses, we're certainly going to consider surgery as a possibility. So let me end with abscessus has high levels of in vitro resistance, meaning laboratory resistance, requires a combination of intravenous, oral, and inhaled therapy, more complex in treating MAC. We need to know if that gene is functional or not as a clinician, because that tells me if I can use a macrolide, and then I can tell you what I expect as far as a culture conversion. Just like with MAC, most recurrences are actually reinfection. People go get it again. And surgical resection is something we need to consider. Don't forget, World NTM Awareness Day, August 4th. I hope your parties are already starting. Okay. All right. Thank you.